Complications are common for patients with diabetes. Unfortunately, in Africa, they often lead to amputations, which in turn bring about a heavy economic, physical, and psychological burden on patients, on their family, and on society as a whole. Before the COVID-19 pandemic, podiatry was not a well understood link of the care chain. With COVID-19, it has become urgent to rethink podiatry care, share good practices, and help design care systems that will rely on collaboration between well-trained and well-informed healthcare professionals. With me today to lead the conversation are Dr. Afokogene Isiabwe, who is an endocrinologist and diabetologist and is the founding partner of Rainbow Specialist Medical Center in Lagos. Together with her team and colleagues, she introduced diabetes food care education to healthcare workers in Nigeria. She's also a founding member of Diabetes Food Nigeria. Sidi Mbonani is a senior podiatrist who serves as chairperson of the Wound Care Committee at Chris Hani Baragwanath Hospital, the largest hospital in South Africa. Sidi provides specialized advice and training on wound care and diabetic food specifically. And finally, Simiso Ntuli, who heads the only podiatry department in Africa at the University of Johannesburg. He's also the vice chairperson of the Physiotherapy, Podiatry and Biokinetics Board of the Health Professions Council of South Africa. He has previous experience working in the United Kingdom and focuses on at-risk foot and the role of podiatry in public healthcare. Keep an eye on the polls that we are running. And the first question that we are asking you today is, what is your background? In the meantime, I will turn to Sidi because, well, we know her background. We know your background, Sidi. As a podiatrist, have you been able to work without seeing patients face to face?
I have never really managed any patient without seeing them. However, it has currently, because of the situation we're in, it's pressed upon us now to manage patients without seeing them. Our job is mostly physical and requires us to be in contact with the patient. So, it proves to be a bit hard, but we try and give advice as much as possible, and we educate as well.
You are also practicing. Can you tell us a bit about how you have managed to work during COVID?
It's been difficult to practice telemedicine. I don't think in South Africa we can boldly say we can do that. So one has been having to go to work and to look at what the setting where you're working has got in terms of protecting oneself. But with regards to us, the profession podiatry, it's been difficult, really. We can't work without touching a patient.
Work exactly, specifically related to patients who are suffering from diabetes. Gidi, can you, people who are not familiar, can you explain a little bit the role of the podiatrist?
Well, from a perspective of podiatry, our role mainly is to assess, diagnose, and manage foot ailments. We play a role in educating our patients. We play a role in prevention in some instances, and looking at the management of foot ailments and foot diseases as well. And we look at advanced modalities that we can use in managing our patients, and such modalities obviously require us to be in contact with our patients. But I find that our role in terms of podiatry collaborating with others, it's mainly looking at how we can manage foot ailments, but improving patient care and a holistic approach in improving the quality of life.
Xiaowei, when do you see patients who are suffering from food complications, and at what point do they come to your clinic? Make sure that the microphone is not muted. You, Dr. Isiawe, while we try and fix. Yes, please go ahead.
All right. We see patients at different stages. The well-informed patients know food care is a given part of diabetes care. But in the rural areas, you still have people presenting very late who already have food ulcers and very, very advanced diabetes food ulcer stage.
Who is the late stage?
I think it's largely due to ignorance on diabetes food care. Anybody who is living with diabetes or any healthcare worker who is well informed ought to know that food ulcer in a person living with diabetes shouldn't be taken lightly, or symptoms of neuropathy, and should be able to recognize the high risk foods and do the needful. But in the rural areas, I emphasize rural areas where they don't have access to standard healthcare, and the healthcare practitioners probably not well informed about food care. We still have people with diabetes developing food ulcers and then doing some home remedies, and then when things get out of hand, before they present to an institution that can manage them.
When Chidi, for a response to this, do you also see the split between the understanding of the importance of food care between rural areas and urban areas in South Africa? Timiso.
I think that will always be there, but perhaps in South Africa, though you have those rural areas, there's a huge migration into town. So urban areas are always problematic, but also I think more than just the rural and your urban. For us in South Africa, is a huge issue around the socio-economic issues that prevail between the two sectors of the communities. So people in rural areas are still staying very far from clinics, from health facilities. There are virtually no podiatrists in those areas. And if there are, those GPs are a far distance to access to. So definitely there is a difference between access and complications between patients that you find in urban areas and those that you find in rural areas.
We also need to look at the culture and how we've been socialized. Some patients have been socialized that the diabetes isn't, they will always say, I only have a little bit of diabetes, or and we look at the mind, the thought behind it. So how people and how patients think. And some would delay coming because of the fear as well. So there's obviously a psychological aspect of it, in addition to lack of understanding of foot care and footwear by other professionals, lack of numbers of podiatrists within the public sector, and obviously looking at the rural areas because they are more affected. We need to look at our patients' thought processing of when they are diagnosed with diabetes and their understanding of that. And I would be a bit cautious in saying ignorance, but more so not knowing because some of the information is not readily available to them. So we have a lot of factors that play a role in patients presenting late to our clinics. And one of the other things is that mind thought, they are their psychological status as well.
On patient education with regard to food care, we were receiving in the comments a comment from Arv Khalsi, who's in Kenya, and mentioning that they are considering, I believe not yet implementing, the possibility of liaising with a podiatrist via smartphone to determine, I understand, what they can do at home and whether they need to come to the hospital for and book an appointment. Is this how you have managed the liaison with patients during the COVID? Are you using applications, or are you helping your patients via mobile phone? Maybe Dr. Isiawe, you want to respond to this?
Thank you. During the COVID period, we've had to embrace more technology, making use of the smartphone via WhatsApp, video call, or Zoom to have meetings with patients. But it's been a bit challenging in the sense that sometimes the network is not too nice, and breaks in communication. But by and large, for the greater part of this season, I've had to move my clinic to more of an online consultation.
If I may jump in, in our situation, it is quite hard to even have a WhatsApp group or an online type of setup. And I think Smiso tapped on that or touched on that in terms of the socioeconomic aspect of it. However, what I've realized we do as colleagues is that we have formed forums, little forums where some colleagues communicate with each other when there is a need or help. And I can see Avrikausi's question looking at communicating via phone. It is quite difficult. However, it's not impossible when there's a lot of programs that can assist. It's just a matter of how do we make it more sustainable as well, and how do we make it more accessible, and as well as looking at the number of professionals or podiatrists who are available at that point in time when the need is needed, so that they're able to give their input and to advise and to make sure that patient care continues.
Well, I think on how patients are socialized. Our patients taught to consult us over the phone. This is a that you now need to phone someone, and then you have an entire conversation in that setting. Data in South Africa is very expensive, by the way. It's one of the expensive in Africa. So this is another challenge. And also the nature of what a podiatrist actually does. Yes, you can give a lot of advice, you can give a lot of education. When a diabetic patient says, look, I think I've got a nail and it's septic, then there's very little you can do over the phone except to say to that patient, you need to come in and see me. So yes, the medicine structures are in place. However, I think the unbundling remains a problem with regards to the patients themselves and actually what we as podiatrists want to do with a patient.
With regard to via telemedicine, and we hear similar comments, for example, from Christelle, who's saying that you can send a picture of the wound and you can advise accordingly, but sooner or later you'll have to actually see the patient. So this really shows the limits of telemedicine in our situation. Now, we've touched on a couple of issues. I just want to point out that we've seen the question from Gideon, who's asking who is asking about several things. For example, the diaspora and the multidisciplinary team. We'll get to this in a moment. But we also touched on the number of podiatrists. And I think it was Andrew who was pointing out that in Western Cape, they have a massive problem in the community with community health centers. There's only one podiatrist working for the province. So let's go to the root of the issue with regard to education and the number of podiatrists in respective countries. Maybe Afoke, you can give us an idea of what the situation is in Nigeria.
As per the number of podiatrists in Nigeria, on the situation of podiatry, since we started the initiative, the Diabetes Podiatry Initiative, there was a huge awareness, and we've had Nigerian podiatrists in diaspora start coming back home to actually do some. They come in, spend 2 weeks, 3 weeks, see some patients and go. And also doing some trainings as well. So initially there was nothing. But right now in the Nigerian curriculum, we don't have a podiatry training program. So what you would have Nigerian podiatrists in diaspora or other podiatrists coming for medical missions or workshop, coming in to take care of patients. And then those few doctors and nurses that we have trained in the art of basic foot care, doing some basic foot care work as well.
About the
Well, if I may begin before Titi comes in South Africa, we are fortunate in podiatrists. However, the issue has been a failure for the state to give proper recognition to podiatry as a service. So I'm saying this is a problem from the state side, but it's a multi-pronged problem really, because there are other can be said. So currently, I think we're not even over 500 podiatrists in South Africa, if that many. I think we are way less. We might be around 350. I'm not sure how many work in the States. I think currently in Gauteng, we're looking at around 50. In the Western Cape, as Andrew says, about 1. I'm not sure if that person is permanently employed by the state or are timing. So there is a big problem with the shortage of podiatry in South Africa, primarily influenced by the lack of understanding of what is it that podiatrists do and what role do they play within the entire health sector in South Africa.
So that links to a question we had from our audience. What are the interactions between podiatrists currently in South Africa, between podiatrists and the rest of the care team? Can you explain what the situation is and what ideally it should be, maybe? Chidi, do you want to start?
We could easily say that failure of the public sector, but we should also consider that the role of podiatry, because podiatry has evolved and has always been known in differently, we have to change. It's a paradigm shift. We have to change how people think and how people have actually considered podiatry to be. Then the role of podiatry and the need for podiatry can be actually seen. And going back to your question, we need to consider the fact that we as podiatrists, we need to find we know where we're supposed to be in space in the health sector, but we need to consider how do we make sure that our role is seen, especially when we look at in chronic management, we look at rheumatology, we look at diabetes, and we look at all these things. It's only sad that unfortunately certain areas don't have access, and lack of access proves to be a bit of a challenge for us.
To Tsidi. There's always been an idea in South Africa amongst the colleagues, and I happen to share that thought, that the whole training of podiatrists in a university that does not have a medical school has been a disadvantage, because you're finding that the medical school will train physiotherapists, OTs, and a host of healthcare practitioners, and podiatrists are trained away from that institution. And that's the first thing maybe that speaks to why is it colleagues are not so understanding of podiatry. The second area where I think podiatrists will need to address on one-on-one basis, podiatrists do very well with other clinicians, for example, with endocrinologists and so forth. But that seems to roll over to policy formulation. How do we escalate those relationships into a consolidated countrywide or nationwide approach that speaks to the role, the need, and actual activities that podiatrists will play within a broader medical setup?
And Dr. Isiawe, so based on what Demiso is saying, there is a need to improve the way podiatrists are perceived and understood, the way their role is understood by the wider medical team. Can you tell us what you have done to improve this understanding yourself at the Rainbow Medical Center, but also through other initiatives?
Okay. In 2014, we started the Diabetes Podiatry Initiative program, a training for healthcare workers and persons living with diabetes, where we empowered healthcare workers, nurses, doctors, and paramedics on basic diabetes food care. We taught them how to identify the high-risk food, how to do food screening, and some basic wound care. And then later on, we partnered with the World Diabetes Foundation, and we were able to expand the training to involve other facilities. Our main training faculty was from the Podiatry Institute, our technical partners. So we had a training curriculum, and we ran this project for about 3 years. We ended 2017. By 2018, we started a short certified program on diabetes food care with the World Work Foundation, the Jamaican chapter, where we developed a 1-week food care training workshop, also targeted at doctors and nurses. And each time we have these workshops, we also have a parallel patient session. We talk about food care, we talk about footwear. And generally the initiative, we had a 3-pronged approach, reaching out to the patients, reaching out to the healthcare workers, and then we also tried to reach across to the policymakers, because like Simiso said, the policymakers, they have to understand the fact that podiatry is a necessary specialty that should be brought to the different levels of healthcare, the primary care, the secondary, the tertiary healthcare. We can start off what we have done at the primary care level with the community health extension workers. They should know how to do the food screening. They should know how to identify high-risk food, and they should know when to refer. And then when the podiatrists are coming, they can stay at the tertiary and secondary care level, but it starts from the community, because if at the community level the people know what to do with food care in diabetes, the community health extension worker knows that anybody that has a food ulcer, you must check the blood sugar to make sure it's not related, it's not associated with diabetes.
Going to be back hopefully, but she made the point on starting with the community. In the comments, we heard about training family members, which is a necessary exercise for better outcomes, but also other people saying it's not always recommended to train family members because they may lack the touch that is required, and that's an expression that I think I've seen about them, the family members being like cowboys. Did you want to respond to this, Chidi?
Family involvement in terms of patient care is important. However, I would agree with Lucas in a sense that there's limitations as to what they are supposed to do and what they are allowed to do. What I would usually do is whenever has to be counseling with a social worker, or I have to teach a patient, I need a family member there. That encourages continuation of care or understanding better of what I'm teaching or what I'm educating about. But it is true, family members can only do so much. As practitioners, we need to be aware that there are family members who would want to do what would put the patient at risk. However, we need to remember there's limitations, and we need to let them know the dangers of what could happen if they had to manage those patients. But it is true, we cannot exclude them in terms of knowledge, in terms of educating them and empowering them to take better care of the patient. But there's certain things that we know they cannot do, and we need to be able to intervene as and when that is needed.
Right. So Simi, Andrew Clark was asking you to comment on healthcare workers and training these healthcare community workers. So we've just covered the fact that family members will not be sufficient. One level up is that community workers.
Look, I think Andrew has got a good point with regards to training of healthcare workers. The issue is not the training. The issue is you need the Health Professions Council to approve the scope that they will work at. You also need the profession, the podiatry profession, to agree to that approach. Now, it's a beautiful thought on paper, and it is doable. However, there is a danger when before you get a proper classification and integration of podiatry into the health systems, you then decide to introduce a mid-level worker, because that mid-level worker can be just the one thing that government needs to say, but now why do we need podiatrists? So it's a beautiful thought, and it's something that we need to investigate at more depth, because it will allow, I saw one comment from Andrew that training of local champions, those are beautiful ideas, but in terms of how you articulate them, how you unbundle them, there might be some considerations that might be needed before we undertake those kind of training for mid-level workers.
Wouldn't just be trained on podiatry care, might as well train them on other aspects.
Yes. Because if you think about it, podiatry is referred to as a specialist care. So it's a specialized field. When you look at training anyone, the first question that you have to answer in South Africa, because of how our education and how the politics are, is after 5 years, how will you articulate that person into a more proper, fully fledged jobs? So now, if our colleagues, if we train healthcare workers, for example, or a mid-level worker in podiatry. The mandatory regulation tells us that after a number of years, that person can come back and get a degree to be a podiatrist. So there are some issues that are educational, some issues that will relate to health that we will need to consider before we roll that out. However, there is no harm in doing a week's course on someone how to identify at-risk food and learn to refer accordingly. So rather than teaching them how to do anything, you teach them to become champions in identifying risk factors in a diabetic patient, who to refer to, how soon to refer, and those kind of things. So they become, in a way, people that can help with the coordination of care rather than interventions as such. That is something that we are looking at seriously, training them to identify and learn who to refer to and those kind of things.
So to be able to implement all of these suggestions, there needs to be a decision from the policymakers, and there may be barriers to understanding the role of podiatrists. That's how do you carry this message to policymakers? The first thing, and the second thing is some of the people with us today are patients, and that they are saying that they have never had their diabetes patients that have never had their feet checked by the doctors. So there is there more than just lack of knowledge? Is that a misunderstanding? Is there a cultural issue with regard to the food care, the care of feet? Can you maybe respond to this, advocate, now that you're back in the room?
Yeah, thank you, Greg. The doctors are aware, but the truth of the matter is that in governments, the public hospitals in Nigeria, the doctors are usually overwhelmed. You have very, very busy clinics, many patients waiting to be attended to. So asking the doctor to spend some more time looking at the foot may not be a wise solution. And part of what we suggested during the Diabetes Podiatry Initiative project in Nigeria is that we suggested that the nurses, while the patients are waiting to see the doctors, the nurses do a general food check, take off your shoes, general food check, and then any high-risk food or any food that needs attention should be brought out and taken for special attention by the doctor. And what we do at our own practice is have a separate day for the diabetes foods dedicated to examining the diabetes. So it's not that the doctors don't want to examine, it's just the resources and then the timing and the number of patients they have to attend to. So they just have to focus on the most important thing. When I was in Cape Town, the foot clinic, the podiatrist would run a clinic, same time diabetes clinic was running. So the people see the endocrinologist or the diabetes doctor and then see the podiatrist before going home. So I think in the absence of a podiatrist, the nurses can help and other paramedics can help with basic foot screening. Thank you.
Thank you. Chidi, you want to respond?
I think we should also appreciate the difference in areas that we work in. Certain clinics, it's busy with GPs and they cannot, or with physicians and they cannot assess. However, I find that if something isn't in your field of expertise, it isn't a priority to you, especially to another healthcare professional. But to someone who's a podiatrist, that's their expertise. That's the first thing they look at. So we should also appreciate that. Another thing is, remember that diabetic foot complications come as a result of diabetes. So quite commonly, one would only concentrate on what the cause is, or what the biggest attention needs to be, which is the diabetes. So in some instances, we should appreciate that yes, there is a chance that the physician doesn't have the time to do that, or because it isn't their area of expertise, they don't feel confident and competent enough to do it. And we know, I mean, I always ask my patients, whether they're diabetic or not, have you looked at your feet ever? And they would say, I don't actually look at my feet, but today I guess I'm going to look at it differently. So we need to appreciate those factors as well, where the feet, as much as they're the foundation of the body, they're not given as much priority based on where they are. And there's a misconception, feet are dirty, etc. So we need to consider all those factors when we look at why is that there isn't a lot of people that are looking at their feet who are healthcare professionals.
To add, Timiso, and we'll go do a round of the audience.
So it's just to add on what colleagues have said. It is important to highlight that most physicians, doctors, and so forth, the only time they use a foot is when a patient reports some issues that they are experiencing with the foot. Now, if you think about it, people think that podiatrists should be involved in diabetic care when there is something that's going wrong with the foot. That perception has changed. A podiatrist starts playing a role on the day a patient is diagnosed with diabetes. This might be as simple as just training or teaching or what have you, but from the day a physician, a GP diagnoses a patient with diabetes, that patient already requires to be seen by a podiatrist. So if that perception can change, you will find that it becomes even more easier to identify and highlight the need for podiatry within the diabetic care team.
I think it goes back to what Andrew Clark is asking. I mean, he's asking if would we look at wound care nurses taking a more podiatry screening and treatment level. And I believe, I mean, when we look at the world in general, there are certain parts of the world where they train on identifying the risks, and obviously with proper training, they can nurses or healthcare workers can actually take part. But as Smiso has added, there's obviously hindrances and red tapes that we need to overcome. But I believe, and this is my own opinion, it is essential that anyone who comes into contact with a diabetic patient, they need to actually know how to identify the risk factors. Once they can identify the risk factors, refer them accordingly to that person who is an expert in that area. And in that way, we have a proper multidisciplinary, interdisciplinary care of this patient. And again, we're looking at not over-servicing the patient, where you find 5 professionals are managing this patient and they're probably doing things that are overlapping. So if we train so that we can have an early detection or identification of risk factors, and those risk factors managed accordingly, I don't think we would have the cases that we're having nowadays.
Answered, and I'll just we'll try and cover as many as possible. Dr. Isiawe, just for you, a question here: what is the role of pharmacists in podiatry care? Do you because you have been involved in multidisciplinary team, what do you have to answer to this?
The pharmacists have a very big role to play. In Nigeria, most people go to the community pharmacy to access healthcare. And what I say to the pharmacists is that good care education can start from the community pharmacy. So your patient comes in to pick up their medication. You see the patient is taking metformin or insulin. That should tell you the person is living with diabetes. And then you look at the foot of the person, see what type of footwear the person is putting on. Is it appropriate? Is it not appropriate? Even without touching the patient, they can offer some level of foot care education to the patients.
So what does it mean? Does it mean that everyone needs to become a podiatrist? How do you manage this training of everyone and having actually the right knowledge inferred to people?
we play soccer in a team, not everyone needs to be a goalkeeper to ensure that opposing team. So we must be sure that we capacitate people correctly at the levels they are at. We also don't want 8 areas of too many gray areas between the scopes of professions in which people are working. For example, we say let's train healthcare workers and nurses. Let's identify that we are training these cadres or these colleagues specifically identify and learn when to refer. Because the more you train someone to actually intervene, then you've actually extended their scope of profession or scope of practice. And I think that is where the biggest problem lies with training other professions, because if I train into doing something, I then become and I can do that independently. So podiatrists must sit down and must decide, how do we train other colleagues to refer to us? How do we highlight to other colleagues that we are also a key member of the diabetic management team from the day the patient is diagnosed throughout the life cycle of that patient? But I wouldn't invite everyone to apply to become a podiatrist at this stage. We will just manage with the few numbers we've got. Thank you.
There was a provocative point that was made in the chat, and I just wanted to throw it at Chidi just for a reaction. Humaira says, a lot of doctors have no idea what podiatrists do and are under the misconception that we just cut nails and massage feet. True or false?
I think, like I've said, podiatry has evolved. However, we find that certain colleagues, and not within podiatry, but within the health sector in general, because of how they've always known podiatry to be, they're thinking even in 2020 we are still just cutting nails and corns. And I would give my own experience when I arrived at Chris Hani Baragwanath. It was already an established clinic. They knew what we were doing. However, when we ventured into specifically the management of diabetic foot complications, it wasn't well received because of how we were previously perceived or how we were known to be doing as podiatrists. And this had to be in us, in our team, to make sure that colleagues understand our role pre-diagnosis, as a patient is diagnosed, during the lifetime of this patient, and as well as when there's complications presenting, whether they're pre-ulcerative or already there's a complication, we have to play a role in the management of those patients. And I feel the onus is in the practitioner to make sure that the rest of the health sector understand what they do and the role they play. And every time, and I always say this, because they don't know, they don't understand, we need to teach, and we will continue teaching. The minute we stop teaching and making sure that people understand what we do, that's when we lose what we are.
And any response to this?
If I may add, I think I will speak from the point that I'm always trying to encourage colleagues on. If a doctor sitting in rooms goes through and the only thing he can find on podiatry is something that talks about chiropody, something that talks about legs and what have you, that doctor will understand podiatry to be that. We do need to maybe beat our own drum a little bit more than we are. We do need stories of our success. So we are very good at treating the diabetic foot. We really are good at this. But how many people, how many doctors open their journal, their article, and find what outcomes are coming from the podiatry sector? So we need to tell our own story. We need to be able to sensitize people how good we are and how knowledgeable we are in our own field. That then means we will get that acknowledgement automatically. But if we hope that we're just going to say we are good and we are not, I mean, it's about evidence-based medicine. We can talk until we are blue in our faces, but until such time that we put on the table some evidence along with the argument, then we will get better results, I suppose.
That's a good point, that in any communications or outreach that's being done that is supported by data. We've actually asked the participants in the room whether they were aware of any podiatry campaigns aimed at other healthcare professionals to raise awareness. So not the patients, but the other healthcare professionals. And I wanted to ask Dr. Isiavere, are you aware of such campaigns? Not in education, not to train specifically healthcare workers, but to communicate about the role of podiatry.
In Nigeria or generally?
Whether you think it's a good idea.
Yeah, I know some pharma companies are having some campaign. It's a good idea because we need to have more awareness on this podiatry and the role they ought to play. They ought to be playing in the health sector in Africa. There's some pharma companies that are involved with a food campaign. One of the pharma companies in Nigeria is doing a campaign called Save the Fit campaign. It's not specifically a podiatry campaign as such, but it's bringing awareness to caring for diabetes fit.
Thank you. Unfortunately, we're coming to the end of the discussion. I wanted to take this opportunity to ask the participants in the room, but also this conversation leaders, whether they would have a single recommendation of an action for policy makers or for other stakeholders that could be carried out. One of the comments that came early in the conversation, and I'm sorry, I don't remember who said it, but the comment was that things will change after COVID. That there's an opportunity there to change healthcare, and so if we seize this opportunity, what we would do in order to improve diabetes foot care? Who wants to start? The question is, because we've got with COVID an opportunity to influence healthcare management and strategy, what would be your recommendation to policymakers or to other stakeholders? Just one very specific recommendation.
And plans are not the ends. They're just a piece in the puzzle, in the process that aims at aligning the country's priorities. One of the things is, let's look at the financial impact of diabetes as a whole, including diabetic foot amputations, and look at how we can reduce that by involving podiatry. And we look at services rendered and access to patients and how we can prevent that. And I can see in one of the comments, one of the attendees was talking about that. The main thing is, if it's a priority, make it a priority. Then once it's made a priority, make it mandatory that in the management of a diabetic patient, the involvement of podiatry should be there, looking at how much money can our involvement can be saved in terms of when we're looking at the financial status of each country.
figures and even harder facts of economic impact.
If I can also come in, I think what CD is saying also those lines is the fact that we just need to flood our governments with data. Look, we in a country where money is not always available. So there's always going to be an excuse that there is not enough money. However, if we provide that data that shows the cost of having such a service from primary healthcare all the way up to tertiary, then the social economic impact assessment will actually be in our favor. And we need to then start also as colleagues now, talking to my colleagues in Podiatry, we need to start saying we must work together to produce that data. So when we have these findings from our settings, let's share, let's use that data, let's publish it, let's make sure that we have contacts now in Nigeria. I will be following up with Dr. Isiave, for example, to make sure that those leads are there and we start comparing so that our governments, policymakers can be sensitized to this issue that we know. They know diabetes and communicable diseases are a problem, but they just need data to prove what we can do as podiatrists.
Dr. Isiave, you've seen change and you've been part of change in podiatry Nigeria. What is the next step? How do we go further?
We build on what the momentum we have gained. Like I discussed before the cast, we have solid food care trainings in Lagos and in Abuja, and to extend the training beyond Lagos and Abuja to the other states in Nigeria, and very importantly for the policymakers to embrace the data we have presented to them. And not just data alone. I think something else we can do is to put faces behind the data, get patients who have had amputations to share their stories. Maybe the policymakers would know that diabetes foot amputation is causing more human and financial damage than tuberculosis and HIV combined together.
Very much. We will have to close this event, and I'd like to take this opportunity to thank you very much. You lead the conversation leaders, but also the people in the room. We will obviously be following up to document what has been discussed, but also discuss with the participants how we can take this further. One thing that I would say on behalf of Diabetes Africa is that we see our role as helping to ensure that the people working on similar issues, people facing similar challenges across the continent are well connected and that we do not duplicate efforts. Again, thank you very much for your insights and for your participation, taking part in this active conversation. I want to just remind you that we do have the possibility of awarding CPD points, and this is done with the support of the Podiatry Association of South Africa. I would like to thank them again for their help in setting up this event. Just follow the link that is on your screen now. And for all the other participants, we will be in contact very soon. And thank you again for joining us. Goodbye.
Bye.